I would like to spend a little bit of time talking about the non-transplant candidates. Although we, I guess, talked about the transplant candidates and we said that maybe they don't need to be transplanted, even if they could. That's what we spent a little bit of time talking about, at least many of them. But then there are those patients where transplant is not even on the table, the so-called non-transplant eligible. And there was the SWOG trial that was published in The Lancet about 2 years ago now. It's an old study that finally was published showing that the 3-drug combination was superior to the 2-drug combinations of Velcade, lenalidomide, and dexamethasone, or bortezomib, lenalidomide, dexamethasone was superior to lenalidomide, dexamethasone in the control arm. Not so surprising, as you said before, John. And now, on top of that, we have another new study that recently led to FDA approval here in 2019, the so-called MAIA study, using daratumumab with lenalidomide, dexamethasone versus lenalidomide, dexamethasone, again showing that 3 drugs are better than 2 drugs. What do you think, Sundar? Is this going to be the new standard of care for the so-called non-transplant eligible, or you think the Velcade or bortezomib with lenalidomide, dexamethasone is going to stay? What's your thinking?
I think it is good that you said that we have to talk about elderly patients, patients who are not eligible for stem cell transplantation. In this regard, these studies have shown incorporating anti-CD38 monoclonal antibody. Right now it is daratumumab, either with lenalidomide, dexamethasone, or with MPV, which was also a study published earlier in New England Journal of Medicine. And when you did that, the daratumumab again added to the depth of response, and in terms of prolongation, there was also improved progression-free survival, and ultimately it shows a signal on improvement in overall survival too. In elderly patient, first of all, the major progress, when you look at the SEER, and we talked about European population-based data, the life expectancy of myeloma patients have gone up. The transplant only addressed people 65 and younger. Usually in Europe, 65 was cut off. In America, maybe 70 years consistently. So I would say that the novel drugs really improved the majority, because the median age is 70 years. So the novel agents really improved the life expectancy of all patients. And these new studies makes it even better, because daratumumab monoclonal antibody with lenalidomide, dexamethasone, all of them are fairly well tolerated. So the adverse events is less, less frequent hospitalization and things like that. And in the older patient, especially somebody is 80, 82, you get one chance to do the best therapy. They are not good after they relapse once or twice, because of physical. As they get older, they get even more debilitated. And the patient's philosophy towards ongoing therapy also dramatically changes. And they don't want more incremental treatment with increased adverse events or toxicity. So for many reasons, older patient needs to be treated with the best treatment available. And in this regard, I find that the addition of daratumumab to len backbone or MPV backbone in Europe, because they use melphalan is actually very welcome, and I do.
So do you think that's going to become a popular regimen versus the so-called VRD regimen in the older population?
Let me put it this way. There is also a Griffin study. Maybe you will talk a little later.
I would like to say that for a little while. We're going to talk about that at the end of the conversation here.
Yeah, so I would say RD data is excellent. Whether somebody will do VRD light and DARA, that's a different issue by itself. But RD DARA is well tolerated, and this study is excellent.
But if we stick to 3 drugs for this discussion here,
this is the best.
DARA Revdex versus bortezomib Revdex. You think that DARA Revdex is an important step forward?
Absolutely. So it's fascinating because, the NCCN, and I think you agree with this, that those non-transplant eligible patients, newly diagnosed, triple therapy is the best. And yet in this study, in the MAIA study, we looked at a two-drug combination, lenalidomide and dexamethasone, which would typically be indicated for those patients who were elderly and frail and aren't going to tolerate triple therapy. So what we showed is that adding daratumumab to those patients, they do better. Surprise. Again, this is the dilemma, because today, at least as I read it, RVD is the standard of care in that patient population, but we don't know if daratumumab is better. So you're asking, Sundar, the question, is this going to become the standard of care? Based on what? It's based on indirect comparisons. As a payer, I deal with that all the time, and you must too, is looking at indirect comparisons and wondering whether or not these populations that are entered into the clinical trial are comparable enough that we can compare the results. So will this become the standard of care? Maybe, because it's well tolerated.
So the question, the study you're asking for is VRD versus DRD. That's the study you would like to see.
Wouldn't you?
I guess we all want, but this is not true only
Well,
for this
I agree.
kind of situation. It's true for everything.
Yeah, but this is where society as a whole is failing, because we're asking and answering questions that are really less relevant than the ones that are most important to patients.
But as practicing physicians, we still have to treat our patients. So when I ask Sundar if he thinks this is standard of care, I think that's the question that he and I face every day.
Oh, and I do too.
So I was asking for his opinion. And he's
I'm not
curious
criticizing his opinion at all.
No.
I'm simply saying that wouldn't it be wonderful if we had evidence to support our opinions rather than just inferential data based on indirect comparisons of trials.
So we know now that daratumumab is very far along in its development for subcutaneous administration. I do think with the sub-Q administration, that's going to make it highly, highly competitive in combination with RevDex versus VRD. And I think the extension of it is also that now you have a potential maintenance therapy with the daratumumab could be given.
Yeah. So once a month sub-Q infusion for daratumumab with an oral IMiD.
What's the
that's
payer's
wonderful.
perspective of that?
If the evidence supports it, we'll pay for it. No, but I think that's compared to, I don't know, what's the infusion now for IV daratumumab, 3 or 4 hours?
Yes.
Compared to a few minute sub-Q
Infusion is 1.5 hours for the third dose.
90
and
minutes.
onwards.
So clearly the sub-Q will become favored if it's equally efficacious, which I think the evidence supports, and it's more convenient for the patient. Why wouldn't we want to do that?